Okay, good afternoon, everybody. My name's John Kinsman, and I see people are still joining us, which is fantastic. So we have a good number already in, but more will be coming. And I'd like to welcome you to our 7th webinar, the Lighthouse series of webinars. We've been having a very successful series of webinars over the last year or so. This one, we have a really interesting, two really interesting speakers, one from Spain, María Romay Barja, and then we also have Miguel Taylor de Arriaga from Portugal. So we have an Iberian special today, which is very, very nice. And what we're going to be looking at is how we work with social and behavioral sciences in outbreak response, essentially looking from what happened during the pandemic and how also some of the things that we've learned and some of the infrastructures that have been built up have become routine. So this is a very exciting webinar. I think we have 60 minutes ahead of us. I am very, very happy that you're all here. We've had some good numbers before, and it looks like we're going to have some good numbers today. Today, the webinar is going to be moderated by Zachary Dessen, who is the Principal Scientific and Policy Advisor at the European Health Management Association. So Zach, I'm going to hand over to you, and please take us through the webinar. Thank you.
John, and a warm welcome to this 7th webinar from my side. Like John said, my name's Zach. I'll just be the moderator today. So any questions you have, I'll try and make sure that our speakers get them in a clear, concise way, and we'll make sure that we can make things as engaging as possible. A couple of housekeeping notes before we get started. This meeting will be recorded, and it will be uploaded to the EVA platform and to the ECDC Lighthouse once it's ready. And questions, as always, are highly, highly encouraged. So if you have anything you'd like to ask the speakers, anything you'd like to ask in general or be discussed at the webinar, please post your questions in the chat. I and my colleagues will be monitoring and will be taking notes to make sure that once we get to the kind of question and answer open discussion section, after our 2 speakers have presented, we will take your questions and we'll make sure that they get put on the stage. So to give you a warm up for thinking about this topic and to kind of get you warmed up, get your minds warmed up before we introduce our speakers, we will have a couple of Slido questions for you so that you can start thinking about the question. So they should appear on the screen. So if you can just open your screen, if you have us in the background, scan the QR code. And our first question, you should see it on the screen, but I'll read it out just in case. It's what type of findings can social and behavioral data provide during outbreak investigations that epidemiological data alone might miss? So as you start putting your answers into the Slido, we should have a word cloud showing up shortly on the screen, and we'll be able to see what your thoughts are. Hopefully everyone's had a chance to scan that, and there's also the link in the chat just in case you did not have the chance. So please encourage to go ahead and join that and start putting in your responses. Okay, so it looks like we've already got quite a few responses. I see perceptions and protective behaviors are coming up large, although we have quite a good diversity of responses here. Yeah, feelings, perceptions, attitudes, I think those can all be grouped together. I think that seems to be our main focus here. I think that makes a lot of sense. The emotions, motivations, yeah, that to me, most of these that definitely seem to fall under one clear theme. I think we can all agree. For me, public sentiments, stereotypes, I think these are really interesting ones that maybe you can keep in mind as we move forward, because obviously the theme today, we're looking at how we can integrate some of these things better into our outbreak responses. So maybe Delia, we can move on to the next question and just have a look at, so same for our participants. If you've been through the first question, thank you very much for your insights. We do have one more question before we get into the speakers. Just to keep you warming up even further, and it's in your country, how do social and behavioral sciences support infectious disease outbreak preparedness and response? And actually, I don't know, has jumped out to a good lead. So hopefully we can answer some of those questions, make you a little bit more knowledgeable by the end of the day. I'm sure that will be the case. But I also see that it's quite popular for behavioral sciences to be used in specific topics and thematic areas, which I think also makes sense because obviously people have different attitudes towards vaccination than they do towards AMR. So we maybe need to tailor our responses a little bit. And I think most of the responses are there. So you can have a look, screenshot it if you want to, just to get a sense of how the crowd is feeling. And with that, I think we are ready to maybe move on to our main events today. So with that, I'm very happy to introduce our first speaker, Dr. María Romay Barja. And she is the head of the Behavioral Health Studies Unit at the National Center for Epidemiology at Instituto de Salud Carlos III in Madrid. And she's the WHO focal point in behavioral and cultural insights. So Maria, thank you very much for being here. Welcome, and the floor is yours.
Thanks. Good afternoon. Thank you very much, John and Zach. I'm sharing my screen. Everything is okay?
Yeah, it looks great.
Okay, so I'm very happy to be here, even if I have a call and I'm not sure if I'm going to finish this presentation with voice, but I hope so. Well, what I'm going to talk about this next 15 minutes is how we use the behavioral science during the pandemic. I will be based on the studies we did in Spain, from which we can still draw many interesting lessons. And as requested for the organizers, I will do it by focusing more on the process than on the results themselves. First, we will start. Sorry, it's not working. Sorry. So, but first, some key insights. We all know that behavioral studies are key to dealing with an outbreak or a pandemic. In all times, but especially in times of health crisis, it is important to understand the factors that influence the behavior of the population. In an outbreak, it is necessary to collect evidence on these behaviors and factors as soon as possible. But if the outbreak lasts over the time, it is important to monitor them throughout. What are the challenges? The challenge we have doing that. The challenge are getting the evidence to health authorities in time for them to contextualize their decisions and how to communicate. Normally, measures to combat a pandemic involve the application of non-pharmacological interventions which require make fundamental change in our habits and lifestyles. So it is very important also to give these results back to the population as well. To start, a brief summary of how it all began. We all remember that we start first with the first patient in early December, and then was the identification of the virus in early January. Then it started to be the first case outside China. Then Wuhan was placed under quarantine. And at the end of January, the WHO declared COVID-19 as a public health emergency of international concerns. From there, there start to be new cases all over the world, and in Europe, Germany, Italy, and Spain were the leading presence of new cases. Were leading the presence of new cases, no? So, on 11th of March of 2020, the WHO officially declared the novel COVID-19 outbreak as a pandemic, and 3 days later, the Spanish government declared the national lockdown. And then, after a month being at home, is when we started to wondering how people are coping with this disease at home, and of course, how they perceive what was happening. So in May 2020, one month later, we did our first behavioral study. What we did was a cross-sectional study in which population age 14 and older was invited to participate in an online survey using the snowball sampling technique, and we did via WhatsApp with a standard message inviting the population to participate and to share the survey with their contacts. What I'm going to emphasize here is that we were at home testing the teleworking, because it was the first time we are using the teleworking. And we had no funding. But in a health crisis, if we have questions that need to be answered, you can just stop or wait for the best conditions to do your study. So we try our best with this methodology at that time, and it worked quite well because we obtained 4,000 responses in 24 hours, which I think it tells us that the population wanted or needed to share their experience and their concerns. And we collect very useful information regarding COVID-19 knowledge, risk perception, preventive behavior, diagnosis and treatment during the lockdown, and source of information and trust. Many of the things you have said on the slide. So after this study in June, 1 month later, in June 2020, the WHO of Europe proposed to all countries to carry out a study to monitor the behavior of the population in relation to the COVID. No? So the Minister of Health, the Spanish Minister of Health, passed the request to our institution. And then we conform a team for 2 institutions, different institutions, and 4 researchers with different backgrounds and experience. But the curiosity that it was the first time that we worked together. And I must say, yes, that it was one of the best output of this experience because we are still working together in many different projects and activities. It is important to highlight in this moment that especially at the beginning, we did not start this alone. We were in contact with different institutions and that we're trying also to implement similar studies and that provide support throughout the process. I want to talk first about Cornelia Best from the University of Erfurt, that she provided the first version of the questionnaire that was used and adapted for different countries at that moment. Also, I want to highlight the BCI unit at the WHO that create a group of work and where we met at the beginning every month, and we still we are going with these meetings. And of course, we also work very closely with John and the ECDC, and also with the different ministers of Spain and different universities. So in July 2020, we launched the surveys with the aim to support the Minister of Health and the population in understanding the degree of acceptance and adherence to the implemented measures by identifying citizens' needs and preference in real time. This study stayed until was implemented from July 2020 to September 2022. The study was implemented in many countries at the same time, as I said before, and we all share the similar methodology. We hired a consumer research company to carry out our cross-sectional surveys. In each round, the research company recruited a sample of around 1,000 participants, aged 18 years or older, from a panel. The sample was always representative of the Spanish general populations in terms of sex, age, education, and area of residence. We got in the total 12,000 participants, and if we add the first study we did at home and a study about unvaccinated people that I will talk later, we reached at the end more than 19,000 participants. So how we did it? Since the beginning, we made our surveys each 2 months. We decided to make our survey each 2 months. Here is the curve of the cases in Spain, and this is our rounds, okay? So this means that in each space between these 2 months, what we did was to prepare the survey, launch it, and then about 3-4 days or even a week, we had covered the sample, and then we have to analyze the data, which was not easy because, as we will see later, the questionnaire was really long. Then we saw the results to our MOH. We publish our results in our website. We attend to the press, and we will talk about that later too. And then we adapt the questionnaire to the new context and the new change in the measures implemented. We asked the minister if there was anything they would like to know, and then we close the questionnaire and launch again and start again. And we did so all over the following 2 years, the next 2 years. The questionnaire was very long, as I say, and it has a lot of inputs that you have already said in this slide. We ask about the knowledge, about the transmission, the prevention and diagnosis knowledge, about the fears of the population, the risk perceptions to get the disease, the severity perception, health literacy. We ask also about preventive behaviors and the adherence to these behaviors, the information sources, the trust on the sources of information and institutions. We ask about their opinions about the implemented measures adequacy. About vaccines, first we ask about the intention to get vaccinated, and then about the behavior, how many bows they have, etc. We ask about holidays. Maybe as you see, we can have Christmas or Easter, so we ask sometimes before the holidays what you're going to do, what you're planning to do, or later on what would you have done. No? We ask also about pandemic fatigue from the 3 round and above, mental health, mild symptoms from the 9 round, and persistent COVID or effects of the pandemic in their lives in the last round. As I say, from the beginning, we were in contact with the Minister of Health, but in December 2020, the Director of Public Health invited us for the first time to participate in an interministerial meeting with all the regions of Spain to discuss the factors associated with the pandemic fatigue and how to address it in their communication strategies. From that meeting, the communication with the minister was more direct and fluid, and in July 2021, we were invited again to present our results about behavior and adherence to preventive measures by age, in order to design strategies addressed to young people during the summer. And also here, despite the high vaccination rates in Spain, in October 2021, around here, with 92% of the population over 12 years of age vaccinated, the Minister of Health requested us to conduct a study on the reasons and factors of people who had not yet received a single dose of the COVID vaccines. In a country where there were so few unvaccinated people, it was not easy to reach them. So we again used the convenient sample strategy combined with a panel enterprise. Through the social networks, we got to more than 2,000 clean and complete surveys. And I say clean and complete surveys because we have some open questions where negationists and conspiracy theorists use to let off steam and tell us all what we think about the pandemic and the vaccines. So, regarding the participants from the panel, we got 1,000 participants. Despite the difficulties, we managed to obtain very relevant information in which we first presented in a confidential report to the Minister of Health, and then we published later. And beyond the fact that most frequent response was to believe that COVID vaccines have been developed too quickly. They are experimental and they were not safe. There were other reasons that were very important also that came out, like structural barriers and health-related reasons such as pregnancy, having been previously infected, medical recommendation, or other health problems. And all these reasons helped the Minister of Health to focus its message about the effectiveness of vaccines and their side effects to obtain an even more high rate of vaccination. As I said at the beginning, measures to combat a pandemic involve making fundamental change in our habits and lifestyles. So it is really very important to get our results back to the people who are making such effort in their lives, in their daily life. So after publish each round, our institution issued a press release that used to generate a lot of interest. And as you can see, we were explaining our results on television, radio, and print media, each time after each round. I also want to mention here our website, because 5 years later, this website is still there, and it contains epidemiological, is public, okay, and it contains the epidemiological situation of each round, the changing measures implemented, graphs. I can see here, show you some of the graphs about self-efficacy and how it was changing through the pandemic, or severity perception, how was dropping down, or the adherence to preventive measures. Here we have really how the trust has not really changed that much. So this web really has the history of the pandemic in Spain. No? Tell us just that story. And we also have in the web the articles we publish with more specific analysis regarding the determinants of these behaviors. No. So in short, 5 years later, I can still say that this web is open and useful to show how the Spanish population lived through the pandemic. To finish, as we all know, in a changing scenario, it's necessary and useful to monitor the knowledge, perceptions, attitudes, and practice of the population. Health behaviors are multicausal and complex, which is why behavioral science needs multidisciplinary teams. I have to say, if you have to deal now with an outbreak in your country or in your region, and you want to do a behavioral study for the first time, don't do it alone. Look for other colleagues who haven't done it before. Luckily, we have now this ECDC Lighthouse and the community of practice also of the WHO in Europe, of the BC unit, where you can go, you can knock to the doors and get support. So, even if I had a lot of experience with such kind of studies before the pandemic, I really believe that we could not have done so well without the support of all our European colleagues. And finally, every effort to communicate and disseminate to stakeholders and society is necessary and worthwhile. Thank you.
Fantastic. Thank you very much, Maria. I think a very complicated and complex project with a lot of data to present and a lot of interesting findings. And I think you did a great job at giving us an overview. I see a lot of questions from the audience about some of the methodology and some of the data. So I've done, and I think one of our colleagues as well has shared the link to your website in the chat. So I think a lot of those questions might be answered there, but I will encourage you to just wait and you can go check that out after the webinar is over. And we will also get to those questions at the end, because what I want to go to first is our next speaker. And I'm pleased to introduce Miguel Pelo de Arriaga and introduce him as the head of the Directorate of Disease Prevention and Health Promotion at the Directorate General for Health in Portugal. Miguel, thank you very much for being here. The floor is yours, and I can see your slides just fine once you full screen them.
Yeah, thank you very much. Is it full screen now?
No, not yet.
Okay, so I'm sorry, just give me a second. Now it's okay?
One moment, it's coming up. For me, it still shows the PowerPoint, just the smaller version with your notes.
Okay, let me do it again. I'm sorry, let me just do it again, try to see if it works as we're playing. Now it's working?
Looks great.
Yeah, perfect. Thank you so much. So let me start. Thank you, Zachary, Maria, also to thank for your invitation and about this possibility to present you the Portuguese experience during the pandemic, and especially the lessons learned from that and where we are now. So Maria told a lot about the methodology and the way as they proceed, and let me also start from there, from the Portuguese position, and then to let you know how did we try to connect the dots and try to making this, which is the subject of my presentation. So moving from lessons identified to lessons learned, which is, I must say, a very big challenge, I believe, for all of us. But then again, we start from the beginning. And I will also tell you about the experience that we had during the pandemic and the information that we had previously, and now how did we move forward. So usually we worked a lot in the field of health literacy, health promotion, disease prevention concerning about NCDs. But then, as we all know, in 2019, 2020, we have like this major event that changed or our not perspectives, but our priorities that were redefined immediately facing what we were challenging. In Portugal, in December 2019, beginning of January 2020, we started to build up our national team on the behavior insights. So that's what we call it back then, and that's how we still are moving it forwards now. And this team, we organize it, and actually we don't have the Cosmos project. We were not involved because we start earlier than the WHO presenting this project. So we developed our team and we started to work on BCI, so in the behavior and cultural insights, and try to get how could we better be prepared for what was coming. Of course, we didn't know, we had no idea about the dimension of or the magnitude of the event that we were facing, but we started to prepare ourselves in order to organize our strategy. So we tried to use our code sentence and our mode, which was to make a healthy choice, an easy choice, and we build it up now to make it slightly a little bit different. So we wanted to make the healthy and choice an easy choice, but also the health protective choice an easy choice. So we tried to develop like that, but then again, we started from the beginning. We developed a risk perception approach since January 2020, and we started to evaluate the risk perception of the population. We use a methodology that we developed. We already have published it, so all the colleagues can access to the way as we did it. I can share you the links afterwards, but we tried to evaluate the risk perception of the population going along, not a sensitive analysis approach, but a little bit more in-depth approach. And with that information, we develop weekly reports. Sometimes it was 2 or 3 times a week, explaining the decision makers about the risk perception of population and which were the subjects that people felt that they need to be more explained. So what were the priorities for the people? So we try to engage communication and health literacy according to the risk perception evaluation that we did. So I usually say that we build up like a kind of a chain, a kind of a factory where we collect the information and then we prepare and we customize the communication facing the perceptions of the population. Of course, this was a lot of work. We developed the methodologies and the evaluation was people-centered, but then with a community approach. We use back then a strategy going along also together the information. And it was with that information, with that analysis, that we built up our reports that we provided again to the decision makers. And the decision makers were the Director General of Health, for example, were the Minister, the State Secretary, the Prime Minister. So we provided the information with the risk perception, the subjects that people needed, that they feel that they need more information. For example, in the beginning, the use of masks, people's behavior, that I usually say it was our first vaccine, and we tried to propose it like that. At the same time, in March, April 2020, we developed 2 studies that we called React COVID. They were also published, so you can access also that information, where we gather information that it was really important for us to ask people how did they felt about how the information and how the communication were reach them. So if they were understanding the information that we were providing, and if they were getting the information that they felt that was needed. Of course, this is not evaluating health literacy by itself. It's evaluating probably 1 or 2 dimensions of health literacy. But then again, during that time, for us, it was one of the most important subjects. If the information, if the communication was getting to people. And we got results around 95% of people in a national based study told us that people were getting the information, and around 96% of them told us that they were understanding what we were trying to explain. Even though we had lots of questions, lots of things that we could not answer back then, but even so, people were getting the information. And that was really important for us. And again, as the pandemic was going by, and during all of this life cycle of the pandemic, as Maria already showed, we were of course going in line in making our weekly evaluations with following our methodology and using like a traffic light approach for the decision makers to understand if the risk perception, what was the level of the risk perception, comparing with our baseline. And this was really interesting because sometimes we needed to focus and to customize our communication. For example, people, imagine in the around summer, autumn of 2020, and we have to remember again people that numbers represent people and not only a number, because people were getting so used to get the daily numbers, the daily updates, that we needed to do something. So even our communication methodology was changed according with the risk perceptions and according with people needs. And then when we started to understand that we're having a vaccine, we started our vaccination campaign. And let me tell you, Portugal has one of the best vaccination rates in the world on our national vaccination program, which was also reflected in our vaccination campaign for COVID-19, especially in the first and second year. But we not did it by chance. We organized ourselves and we did, in the beginning, 2 rounds of a study when we knew that we were getting a vaccine, trying to understand which were the most hesitant persons to get vaccinated. And we did this study in a national base again, and we could identify immediately who were the more resistant people to get vaccinated and the main barriers and predictors on vaccination. And that information also allowed us to customize not only our vaccination center, but also how to get to people. And we also, with that information, we define like a kind of a triptych where we could provide them to the health professionals, saying what should you do and say if someone wants to get vaccinated, if someone has questions, or if someone does not want to get vaccinated. So we provide this tool in order to get people more in the professionals engaged with this approach. We also developed different strategies and actions. I will let you know a little bit more afterwards. But this, all of this knowledge, all of this experience, get it to a point where we clearly understand, at least from our side, that we could not work health literacy as a powerful health promotion tool by itself. So we organize ourselves in a way, as I was mentioning in in my first slide, getting the dots together and getting the identified lessons as lessons learned. So we had previously a national action plan on health literacy, but after the pandemics in 2023, we changed because it was finishing, and we got an evaluation, our national plan on health literacy, and we developed now and since then a new plan on health literacy and behavior science. And why? Because we believe, and we divide health literacy in 4 axes, and the last one is to apply the knowledge and the information that we have. And we believe that for that last X on health literacy, we do in fact need behavior science to be on board and to be really effective and to train and to get different approaches on this field area. So that's why, as one of the identified and we hope learned lessons, we put together the behavior science with health literacy in a continuous procedure and approach for the policy level. So within the Director General of Health, we organize ourselves, and our plan now is built up in the experience that we have during the pandemic. And that for us is really important because it leads us to this strategical axis that we define, getting the knowledge that we have previously. So again, we identified our best practices in health literacy, not only, and we started from there, non-communicable disease, but also for communicable disease. Also something that we call health literacy intelligence, which was something that we developed during the pandemic, going along with the same subject of epidemic intelligence, but adjust for health literacy, where we developed and collect information that could allow us to customize the information to get to people. And I can give you a very simple example. We organize ourselves in this social mobilization with this, also one of the axes that I will show afterwards. An example, for example, with the National Guard, with the fire department, with the police. So we had them a different role. For all of those that during the pandemic had to be outside on the street, we had them from health a different role. So to explain to people what was the pandemic, how it was transmitted, and how can we be protected. And those people, those professionals, then again was giving us information like a kind of an observatory where they allowed us to get information, for example, and I do remember this, I think it is a very clear and good example, for people to tell us, okay, inside schools, kids are doing really, really well. But then when they are leaving school, they all get together and go home together with no mask or with no protective issues. So that allows us also to customize and to organize not only our communication, but our actions, knowing and having this information from the field. Of course, communication was had a central role within our planning and also in our new plan, as well as this social mobilization project that we don't want to make it as a beautiful name. We in fact organize ourselves. This is something that we are still doing today as one of the most important actions to reach people. And allow me to give you an example. Now we are still doing this risk perception evaluation and this social mobilization project, for example, not only for infectious disease, but also for heat waves, where you have professionals from social services, also from the National Guard and the police that are visiting people 65 plus or with some disease that are in bed, and they provide them not only information how they can prepare themselves facing a heat wave, but also to provide them something as simple as to provide them water when they are going to their house, which prevents mortality. This is not, I usually say, rocket science. This is something as simple as promoting hydration for people. Then one of our axes as well is the health promotion ecosystem. I'm sorry, I'm trying to do it as fast as I can because we don't have that many time, and then I will give you some answers, of course, in the questions that you have. The health promotion ecosystem, it's one of our major axes now because we are trying to plan from different settings and with different stakeholders to organize ourselves, again, to have the easy choice as the healthy choice, and of course to work in health policies within all of our disengagement. So our intervention are still focusing in to make it accessible and with quality health information, to reach people, focusing a people-centered approach, of course, knowing about the importance of working with the communities for public health, to work in a very just way with communicability, and also, and again, and always learning from the experience that we are having. So we want to promote a community ownership and engagement, to maintain a proximity communication and tailoring, adjusting with the information that people need. Nowadays, and allow me to give you this example, someone that has, for example, diabetes, they don't want to know generic thing about diabetes. They want to know information that is concerned about their daily life for themselves. Generic information like Google something, it's not enough for people nowadays. That's why we are also now working with AI a lot to try to provide and to customize information that in fact people do feel that they need and that is focused for themselves. And then to get quickly and to build up and to maintain trust. And this was one of our major points here, and that we share with colleagues from different countries around Europe, especially during the vaccination campaign, where people do in fact trust in vaccines in Portugal, and also because they trust a lot in health professionals and in health institutions, which for us is of course a plus in the way as we work. And then to train our micro-influencers, our stakeholders, and of course, to train them in communication and not making them health professionals, but to bring them on board to help us out when we have a kind of an outbreak, a pandemic, or whatever. Our code sentence and the thing that we really want to reach with our national plan on health literacy and behavior science now is exactly what is written here. We want to transform science into knowledge, but we don't want to stay there. We want to make knowledge into behavior. Otherwise, it will not make sense to us. So we want to use health literacy to make it everything clear and objective, but as well and at the same time to be possible to be customized for each one of us. It's a huge challenge, but if we want to transform and if we want to make and to build up ecosystems that promote health, we need to be like this and working like this, at least from our side, is the approach that we want to reach. Thank you so much for your time. Thank you.
Thank you very much, Miguel. I think that was a really good overview of a lot of different programs and a lot of work that I know you've done over the past few years. So thank you for giving us that overview. I know for the audience, they're very curious to read a little bit more because you presented so much information, but I know you mentioned you'd be able to share the links. So just rest assured to the audience, the links will either be in the chat today or we will make sure that they're available on the ECDC Lighthouse afterwards, probably both. So with that, I'd like to bring Maria back in because we have quite a few questions from the audience. And again, please keep the questions coming if more things come to you in the chat. But Maria, I want to bring you back in with basically following up on the last thing you said, which I think is really important. You said, if you want to do this work, you should not try to do it alone because you had lots of support from ECDC, WHO, and the Ministry of Health. And I'm curious, maybe if you could expand a little bit more on the nature of these collaborations, how you work together to share behavioral science and social science insights, how you learned maybe from WHO expertise or ECDC expertise in developing your own project, and what was the way you worked together, I suppose, is the basic question.
So, well, at the beginning, we have a lot of doubts, everybody, no? We have a lot of questions and we have a lot of issues that we have to solve, no? The first one was the sample, no? And the sample, everybody decided to be 1,000 for each country and do it with a panel company. So we just were, especially at the beginning, we just were having meetings and meetings and meetings, and the people in the ECDC was always ready. John was always ready to have a meeting, and everybody, we were all in the same boat, no? So we were all willing to share our experience and to share our problems and to solve all the problems together. So it was just very quickly, but a little bit improvised, you know, and the thing was that the WHO was there and the ECDC was there to answer any question we have.
So that's one thing, because you all, I suppose, speak a bit of the same language. You all really understand the behavioral and social science aspect. But Miguel, you mentioned something about working together, sharing your insights with government officials and others at the Ministry of Health. It made me think when you said we have to tailor our communications to the public. I'm imagining you also had to do the same to tailor the communications to the government officials to help them understand. I wonder if you could share a bit more about that experience and some of the lessons you learned.
Okay, thank you so much for the question, Zachary. In fact, we did our best to organize like our weekly or sometimes daily reports were like a one-page report, and we tried to do it as systematic as possible. So we got like the traffic light approach. So we show them a graphic and then recommendations facing and telling, okay, so people feel this is an issue or they need more information about this. So our proposal is that you could communicate saying this, and this. So it was a very, very simple paper. Of course, it was also, as Maria was mentioning, confidential that we did, but it was like a real-time approach. We did not make our research for the future or retrospective. We were trying to make them like a real time because we felt that behavior was so important and probably our only tool to work with the community that we really needed to have something real time. So being in one of the Ministry of Health agencies, it was easier for us to reach the Director General, which was the national authority for the organization of this area, and again also for the minister. So we provide them all the time this information, and they could organize their speech, their daily reports and communications using the information that we had.
I think the idea of giving real-time direct advice is good advice for speaking to politicians at any level. And I'm going to stick with you because we have a question from Renu in the audience who's asking about your new health literacy plan that you've updated to incorporate behavioral and social science insights. And she's asking if you could tell us a little bit more about it. So how were these behavioral science aspects incorporated into the plan? Was it through health professionals or citizen engagement? And how did it build onto the plan that you already had in place?
Okay, thank you so much. Okay, for us, we really felt that these two subjects needed to be together. Because for us, it was extremely important. Health literacy, as we know, it's a very powerful tool. At least we felt it's a very powerful tool because when we do the surveys on health literacy, we get a lot of information that can help us out to identify which areas should we focus the most. And in Portugal, we have one area where we are really good, but with big challenges, which is vaccination. And we have another area that we are not as good, which is navigation within the health system. So we know this with health literacy, and we know that we need to provide information to people, but it's not enough. So in the application of the information, let me give you just this example. So most of the people that are here, like we are health professionals. So being a health professional, does it mean that we have only eating healthy food, having a healthy lifestyle, not drinking alcohol or smoking? Maybe not. So we know that sometimes you have the best people with the best knowledge, with the most recent evidence, and even so, our behavior sometimes is not adjust with that. So we really felt that we need to do it differently. So we put together health literacy and putting it together with the behavior science in order to organize the ecosystems and to provide tools and all of the needed resources to provide not only for health professionals, but as well as to the citizens approaches in order to build up an ecosystem. This is our vision. Our vision is really to have an ecosystem that is health promotion, health protective. It's a really, 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 I would say, a big vision that we have. It's really hard. It's not an easy job because this means that we need to have like changes in a societal level. So that's why we are now working with the different stakeholders, with different settings, for example, like health in school, but now also health in universities, which was something that we were not considering in the past years. It was a kind of a gray approach for us. But now we are building up or trying to build up on this more integrated approach. Not working with silos, we are trying to have this plane as the glue for the different approaches that we have in health.
Indeed, I think ambitious approach is a good way to put it, but I think it's a fantastic way to approach it as well. And that actually is a good segue for Maria to bring you back, because a lot of the questions we have from the audience, I'm going to try and put them all into an easier to digest form. But a lot of them are about that methodology aspect and the practical side of things. How do you reach all of these different levels of society? How do you understand what they need and reach them effectively? I know you mentioned you have panels, but people wonder, is there a cost available with, is there a cost associated with specific parts of your survey in case they wanted to undergo that in their own country? How did you reach the people who are vaccine hesitant? I can imagine that would have been a unique challenge. And how essentially did you design your survey, knowing that there's all these different things going on in the background, different case levels, different levels of vaccination, and different severity, let's say, of the government responses?
Well, it's a lot of questions about the methodology to reach the people. In the first study, as I say, we did it through a snowball methodology. That means that we send a message via WhatsApp with a link and a message saying to the people to fulfill this survey and inviting the people to do it. And then I send it to all my colleagues and friends, and they go on sending and sending and sending. As I say, I think it was the moment. No, we always say you have to be in the right place at the right moment. I think it was just the moment. We had been for 1 month and a half at home, isolated, and suddenly someone is asking you how you are doing, how you feel, what are your fears, and all these things. And the answer was amazing, really. And also it was, of course, we had some bias because we don't reach all the people. The people need to have telephones and to have Wi-Fi, etc. But it was quite representative of the population. The other studies we did with the Cosmos Spain, it was a panel. What is a panel? Yeah, a panel is a company who has a lot of people there. They know the age. Well, they know the people who is already give the consent to participate in different surveys, and they know the categories, the more sociological aspects like that. We can ask to the panel, we want to be representative in age, in sex, and in education, etc., etc. So they choose the people we want more or less in the whole panel, and they send the questionnaire online, and then we start to receive the answers. And of course, that was more representative than the other one. It was really very representative. Regarding the confidence on vaccines, well, Spain is a very strange case, or a different case in Europe, no? Because really in Spain, the confidence in the health system, the trust in the health system is very high by the moment. Really very high. Until the COVID, the majority of the population feel trust on our health workers, really. And even so, the MOH our minister want to know more, because they realized that there were some people who will not reach them with the vaccinations, no? So taking the evidence we got, because there were infrastructure barriers also, because the vaccination was doing in several places where the people have to go there, not in the center at that moment, the health center, and the health center at that moment. So they start just to fulfill the requirements and the needs of the population. This is smart part, as I say, we were 92% of the population already vaccinated. So it's an 8% of the population. Some of them, they will never get vaccinated because they were negationists, but the people who were scared about their health conditions, they get vaccinated later.
Great. And following from that, I'm going to move to a question from Ginity in the audience. I mentioned, I asked earlier if you were working upwards with WHO, ECDC, but did you also work with local and national community organizations, NGO, or specific initiatives? And was that helpful in reaching some of the population with these different initiatives, surveys, messages?
Yes. As I say, we work with the national authorities of health, at the Minister of Health, and then at the regional levels. No, we went to some meetings with them. What it was missing for me, really, in this study is two things: is the community involvement, more community involvement, and we were not able, because we were too busy. As I explained you, that each 2 months we have to do all the things and the rest of our work. So it was very difficult really to reach the population, or to do some qualitative studies. I miss that. It will be very nice always to do some qualitative studies and to have more in-depth information about the population.
Makes sense. And I'm going to actually combine a couple of questions along a similar line for you, Miguel, because Barbara and Dr. Rimela in the audience are both asking about working with the uniformed professionals, so the police, the firefighters, the paramedics that you mentioned, if they needed specific training to make sure that the communication they were giving to the public was accurate, because even as you mentioned, I think people really have a high trust in healthcare professionals. And obviously, if they're not giving the right messages, if they're giving misleading information, it can become even more of a problem. So I wonder how you both managed, let's call them the uniformed outreach or community professionals, and let's provide, for simplicity, we'll call them general practitioners, but the healthcare providers as well.
Okay, thank you so much for the question. So for the, I would say for the first group, with the uniform group, as you call it, we did something that was to organize webinars, and we start also in March 2020 for during the pandemics, and we organize along with the civil protection. At the same time, in the 18 districts of the national mainland, we organize at the same time, at the same hour, a training, a webinar. It was still in person, because we still were not in lockdown. It was still in person, of course. We organized them and we trained the people exactly with the same information. So first we did a train the training, where we use students, especially young medical doctors and nurses and psychologists that were helping out with us, making this training. We trained them first, so train the trainer, and then that 18 trainings, webinars at the same time. But we were not providing them information to be health professionals. We were providing them information, I would say generic information about the pandemics, how did it spread, but especially how could they communicate the behaviors that people needed to have. And we did also something else. We provide them a toolkit, a communication toolkit. So all the posters, all the leaflets, all the information was exactly the same in all the country. And this allowed us also to organize the information, to prevent that people were spreading information from different sources and different information in the same project. So we tried as much as possible to organize ourselves and to prepare to provide them this same information. Of course, that those persons, we were having all the information and different webinars with the updates. And the first one was what to do, what is the pandemic, and how can we prevent, and how can we communicate. And the other ones were knowing that we have more non-pharmacological interventions, what could you do more? So it were adding extra layers throughout the pandemic to our different stakeholders. Of course, it was a challenge because some of them were changing, some of them were different people. So that forced us to adjust the webinars that we were doing. And one of the last ones that we did was with pharmaceuticals, people from the community pharmacists, along with the National College of Pharmacists, to provide them information about vaccination. Not, of course, trying to explain pharmaceutical how a vaccine was produced, but how to communicate and how to engage people, the confidence, the needed confidence and the needed information to know how to navigate within the system to get vaccinated, and how to explain people the importance of getting vaccinated. And this was really, really good for us. We tried to evaluate it. We also did something with WHO on the evaluation of this micro-influencer project that we have, also with the same in the same organization that Maria was mentioning, because I'm also the national focal point for this BCI unit. But this evaluation in the way as we want to move forward was also very important for us. And as I told you, approaches for NCDs, for heat wave, for all the public health emergencies mostly, but we want to keep on working information because this is really, really good. This is really a centered person approach and really to get to the community and to get to people, which is, I believe it's the most important thing that we need to do.
Certainly agreed. And I think you answered this question already from your side. So I'm going to give Maria the last word on this question from Florian in the audience, which was simply the population that's resistant to being vaccinated. How did you convince them to be vaccinated? And Maria, I'll just ask for, it's a complicated question, but what would you give as your one piece of advice if you were going to say this one item from behavioral and social science would be my recommendation?
Well, I don't think there is one formula, magic formula always. But well, of course, what I was saying is to keep as much evidence about the fears and of the reasons of not getting vaccinated as much as we can, and then address these issues from a communication campaign or from the Minister of Health or from the health center or from the doctors. It's just that, and I would like to say also, as I said before, now that we are still working together, this team that we conformed during the pandemic, and we have now a very nice project. It's mapping the health behavioral studies in Spain, and their impact in health policies, and services and communication. And what we try to do really, in addition to knowing who is doing what is very important because we don't know in Spain. We don't know all of us, who is doing what in behavioral science. We want also to create a community of practice like this one, but a Spanish community of practice, to have the people from the size of the public health and the people from the size of the scientifics to put them together, because many times the evidence is there, but the people from the public health don't know it. And it's important to contact all these people, to put all these people together to work together for the future.
I think that's a fantastic message for us to wrap up the discussion. So I want to give you both another huge thank you from our side. Thank you for being here. Thank you for engaging, and thank you for the audience's questions. And I hope we did our best to answer as many of them as we could. So my colleague is going to put a code on the screen shortly. If you have any feedback about how these webinars are run and in topics perhaps you might want to see in the future, you'll be able to fill in the form, and we highly value your feedback. So please go ahead and scan this code and give your feedback. And with that, I will give it back to John for some final words.
Thank you, Zach, and Maria and Miguel. Thank you so much for an incredibly inspiring hour. It's been really amazing, actually, to hear all of these stories of things that didn't happen so very long ago, but all of them are sort of lodged in our memories, and very often we don't want to think about it very much. And it was somehow very comforting to hear what you were all doing behind the scenes to make things better for the people in your two countries. And it's inspiring and wonderful. And I think a lot of lessons learned there. So thank you for your incredibly eloquent and broad and comprehensive presentations. Enormously appreciated. Thanks to all of the participants for joining. We had, I think, something around 300 people with us today, which is pretty fantastic. A lot of really interesting questions came up in the chat. We couldn't answer all of them. I think a lot of them got touched upon. We couldn't answer them all, but please bear in mind we're going to have follow-ups in the future within the Lighthouse. And the Lighthouse, you know, is our online community of practice. So we'll be having some sort of community event where we'll be discussing some of these issues in more depths. So please sign up for the Lighthouse, get involved, and you will hear all of the updates and everything about what we're working on in the future. So please go ahead and do that. The next webinar is going to be after the summer in September. You will be notified of this and so on by email and through social media. We're looking forward to more contacts with you. We're looking forward to continuing with the webinars and to all of this great work. So thank you so much for your patience, for your being with us this afternoon. And again, thank you so much, Maria and Miguel, for inspiring us and giving us so many good things to think about and good things to learn. Have a lovely afternoon. Thank you.
Thank you. It was a pleasure.
Thank you. Bye-bye.